Hi, this is E. David Crawford, Editor-in-Chief of Grand Rounds in Urology. Joining me is Dr. Brian Moran, who is Medical Director of the Chicago Prostate Center, which he founded in the early 90s. Brian has been interested in prostate brachytherapy for a long time, and his group there has done over 25,000 implants. He's also been on the cutting edge of transperineal biopsies and done a lot of those, and also he's done a lot of targeted focal therapy, and we're going to be talking with him about that at a later date because he has some publications coming out. Brian, like all of us, has been sort of met with a challenge with this pandemic of COVID-19, and we're going to talk with him about how he's dealing with it in his busy practice and what's happening. So, Brian, thanks for joining us. We appreciate it.
Well, thank you, Dr. Crawford. It's quite an honor to be on this program. Obviously, this pandemic, if you will, has, overnight really affected medical practices across the board. And it really has affected my practice, and it's been very interesting. We're trying to make observations as to the patients that are coming in, the patients that are deferring evaluation, and it's been fascinating. Our number one competitor, if you will, is external beam radiation, which requires anywhere between 9 weeks of radiation on a daily basis, or to some of the hypofractionated protocols that might not require that much treatment. So we are seeing patients that are coming in because they would like to have a prostate seed implant, but we're also seeing patients that are coming in because they don't want to be exposed for a long duration of time receiving daily treatments of external beam radiation. And so that's the first time that's ever really appeared, and it's not because of the inconvenience of the daily treatments. It's really because of the exposure of being in the public or being around more than 10 people, and so that we're seeing an increased activity in that specific subset. The patients that we treat, Dr. Crawford, typically are seen in a consultation basis, at which time they would be evaluated for if they're a candidate for brachytherapy. And at that time, we would just schedule them. And so it's really 2 visits. I mean, they come in one day and they are scheduled for surgery down the road. Now, we are an outpatient surgery center, so we do have the availability to do elective things contrary to the recommendations of the government, because we're just a small place. But we've cut dramatically back because we don't want to be using supplies, obviously, that the hospitals can use.
What's the brachy? I mean, I'm talking to people hearing about that elective surgeries are being delayed, and certainly prostates and things like that. But I know in brachytherapy, it's often part of a trimodal therapy. And what's your feeling? What's sort of the bottom line about the urgency of the implant in these patients?
Well, you brought up a very good point, and one that was just addressed by the American Brachytherapy Society literally yesterday. And they came out with a statement saying that we appreciate the guidelines, we will honor them, but we are advising our doctors to say low-risk patients can be delayed and be considered elective. However, there are patients with very high-risk, unfavorable cancers that are currently involved in, say, a trimodal protocol. And that typically is upfront androgen blockade followed by external beam radiation to the pelvis and prostate, pelvic lymph nodes and prostate, followed by an implant. And that is a timely thing. I mean, you really can't delay those. They typically are those procedures, whether they're low dose rate or high dose rate brachytherapy, they're usually done within 2 to 3 weeks upon completion of the external beam component of the trimodality. And it's really important. We call this time dose fractionation. And you really don't want a significant delay before that boost implant, because that is what has proven itself in the recent AscendRT study out of Canada, showing a dramatic difference in these high-risk patients versus IMRT, conventional IMRT. I mean, that's a novel paper. Their toxicity was greater, I give you that. But again, I think that they should be considered pioneers. We didn't have that toxicity, but then again, we weren't that aggressive.
Right, and timing is important in some therapies, and we're seeing that. Anything you're doing special? I'm sure you're using more telemedicine for initial consults, maybe post-op follow-up and things like that. But anything unique about how you're treating patients in your center? I guess you're separating them in the waiting rooms and things like that.
Yeah, we are. The patients are separated, but the volume is low enough that we're able to really just see them when they come in, check in, and then we take care of that patient. He's out the door before the next one's there. So scheduling's been important for us. Again, our volume is down 80% compared to the typical clinic volume. Telemedicine, I did my first one the other day. I mean, I'm not the most computer literate person, but we managed to get through it, and yeah, I can do it.
Right.
So we're probably seeing 80% of the follow-ups in telemedicine venue.
So your volume is down 80%. That's a significant financial hit. You've got a lot of salaries to cover and things like that. What are your thoughts about that? Sort of in the next minute or so of our talk here.
We recently joined a larger medical group, so our employees are doing a lot of cost shifting. Believe it or not, probably 60% of my team is now working in urgent care centers, staffing those to help out the rest of the, group. We're team players, and yeah, I mean, there's not enough work for my team right now, and it's hard. It's very hard. But everybody's grouped together. Nobody's lost a job. They're just all, being with a can-do attitude, and they're willing to go to other sites to help out where they need the help.
That's great. Well, thanks for sharing your experiences, Brian. We've learned a lot, and keep up the great work. And we look forward to talking to you in the next couple of months when your papers come out on your long-term treatments and your focal therapy. So have a good rest of the day.
Biopsy date will be great. Okay, thank you, Dr. Crawford.